This conference will now be recorded.
So welcome to the class. So in today's class, I'll be just discussing this cervical Cerclage guideline. It is the latest guideline, and there are few updates from the previous guideline. So, so, so what type of cerclages are there? According to this, so what I'll be speaking would be according to the guideline only. So what type of cerclage are there according to this guideline? So they have divided them in the three types. So it would be history related, it would be USG ultrasound related, or it would be emergency. And what type of stitches are put? Either it could be vaginal will be low vaginal, so this is the low vaginal, or it could be high vaginal, or it could be transabdominal. So like in upcoming slides I'll be speaking about this, but these are the three types that are done, and these are the three types according to the types of cerclage: history related, USG related, and emergency cerclage. Okay, now why the cerclage is done? So what they see that cerclage may provide degree of structural support and help, so that it can maintain cervical length, and also it maintains endocervical plug, so that happens to be maintaining barrier to the ascending infections. Okay, so apart from this, now history related cerclage. So history related cerclage, now what are the where it could be done? So if the patient is having single pregnancy, apart from this, there is a history of three or more previous preterm birth. So these are the two criterias. So if the patient like fulfills these two criteria, then on the basis of history cerclage can be done. So uh, and usually, as it is history related, so it is done use early, like it will be done 11 to 14 weeks of pregnancy. This is like everything what I'm speaking is from the guideline only. Now this part would be important for part 2 people, because SBA EMQ will come, and for part 3 people also important, whatever the history role player is giving, you should have a very clear cut idea which patient you can offer cerclage. Okay, and usually because it is in history related, so and it is performed as a prophylactic measure, and the patient has got no symptoms, so it can be planned early in the pregnancy, that is 14 to 11 to 14 weeks of gestation. So this is another area where the question can come. And apart from this, you guys can understand, if the patient is pregnant, early it is done, better it would be, because later on the uterus becomes big, and putting cerclage around the cervix become difficult. So in this history related, because of that, they are doing it early, because the patient is asymptomatic at 11 to 14 weeks of pregnancy. So this part is important for both part 2 and part 3 people. Now history related cerclage, why they are offering it? Because according to the available evidence, if they offer history related cerclage, then incidence of having preterm would decrease by 50%, or it would be half before 33 weeks of pregnancy. So this is the like reason behind that the history related cerclage is offered. On the other side, according to the available evidence, if the cerclage is offered three less than three preterm losses, then it is not effective. Because of that, according the evidence is there for history related cerclage should be offered when there is singleton pregnancy and three or more than three preterm losses. So apart from this, uh, again this is the same thing: singleton pregnancy, three or more previous preterms, and also like sometime the patient would not be able to uh, tell the clear history. So I like these are the few things that will help in identifying that patient has an history. Leading question can be asked about the painless dilatation, about the rupture of membrane, or prior cervical surgery. So few things patient will tell, that will help if they are unable to speak about the like history. So this would be sort of a leading questions. Then this is about the indications for history related cerclage. Now coming to ultrasound related. So ultrasound related cerclage, like it is not prophylactic, it is therapeutic, because we have seen on the scan that the cervical length is decreasing, so it is therapeutic measure. So like is ultrasound cerclage can be in on a when the patient has no symptoms and like fetal membranes or feet are not exposed. So usually sonographic assessment for ultrasound related cerclage is done in between 14 to 24 weeks of pregnancy, usually by TVS, and bladder has to be empty, because if the bladder is full, so it may give false appearance of increased cervical length. So if the ultrasounds related cerclage will be sort of a therapeutic measure in a asymptomatic woman. Now like few thing is there. One thing, so this is just a question for you. If the 32-year-old woman with a previous history of pregnancy loss, now she's for the cervical screen, and you find that there had been like funneling of cervix, and the cervical length is 33 mm, should the cerclage to be put here ultrasound related or not? Anyone can answer?
Ma'am, funneling the cervical encephalage is not recommended.
Very good. So no, cervical ultrasound indicated cerclage is not recommended for funneling of the cervix, and in absence of a cervical shortening to 25. So now you can see just an visual impression. So this is funneling, and the internal there is a internal os dilated. So this is funneling, but on basis of this, there would be no they will not offer cerclage. Measurement of cervical length is done. So if it is less than 25, then only it would be offered. So in the question wherever I have put it, I put the cervical length 333, so it is not indicated. Now like cervical history, yeah, USG related cerclage, when it is done, they should have at least the history, patient should have an history of one or more uh, like spontaneous second term loss or preterm birth. So then only like ultrasound related cerclage will be offered. So it is the same thing what we spoke. So like usually when we already know when the patient has previous preterm or the spontaneous pregnancy loss, cervical screening is done, and on the cervical screening, when the cervical length is less than 25, then only this would be only the indication. The important part here is is to remember that if the patient comes and patient has got no history of any preterm or any mid trimester loss, and on the cervical scan, the cervical length is less. So that time, like if the incidental short cervix is found and the patient has got no history, in that case cervical cerclage is not offered. So like it has to be very clear that I'm repeating it again. For history related cerclage indication, three or more pregnancy losses. For ultrasound related cerclage, there should be history of at least one pregnancy loss, and they should be on cervix, should be less than 25 mm. These then only cerclage will be offered. And if the patient has got no risk factor, and suddenly we got like short cervix, then no cerclage would be offered to that woman. So now you can understand that history plus USG scan, cervical scan length less than 25 is in criteria for USG related cerclage. Now this part you can expect question, uh, because this has been added new in this guideline. This was not there in previous cerclage guideline. So what they say, like they have divided the women in two groups. So like USG cervical, USG surveillance of cervical length. So they have divided the women in two groups, high and intermediate. Now these are the high risk women. So you can get question from here. So what are the high risk women? Those have preterm birth and mid-trimester loss 16 to 34 weeks. Second, if there had been prom 34 weeks, if there had been previous cerclage, if any known uterine variant that and if there had been intrauterine adhesions, and and if there had been history of trachelectomy. So in if the patient has got this kind of surgery, then preterm prevention specialist, patient will be reviewed by the preterm prevention specialist by 12 weeks of pregnancy, and cervical scan will be offered to these women every 2 to 4 weeks in between 16 to 24 weeks of pregnancy. So this part you can we can expect question, because this is newly added in this guideline. So this you have to learn that these are the high risk women. So they want to screen them more. By every 2 to 4 weeks they are doing scan, and the period of in between 16 to 24 weeks. So this is very important, because you may get question. And even the part 3 people, they can get question, like for example, they can what type of question could be there? The patient has an history, trachelectomy has been done, now she's pregnant. So in that situation you have to explain role player that cervical screening will be done at every 2 to 4 weeks by specialist person in between 16 to 24 weeks of pregnancy. So this part is important. On the another side, they have they have put some category of the women in the intermediate risk. What are those? If there had been previous cesarean section as full dilatation, if LEDs has been done, and more than 1 centimeter cervical tissue has been removed on the cone biopsy. So these are the three women, the three category they have put. And in this woman, they will be doing only single scan in between 18 to 22 weeks. So this part is different. You may get question from here only. So like high risk women. Now what is the difference? High risk women, the scan will be done every 2 to 4 weeks in between for 16 to 24 weeks. And intermediate risk women, the scan will be done, only single scan they are doing, and in between 18 to 22 weeks of pregnancy. So this part is important for both people, uh, like for both part 2 and part 3, because in part 3 the small changes will be there in the station. And if it is correct answer is not given, so they make you borderline the applied knowledge. Now another question. So 32 weeks year old woman with 26 weeks of pregnancy, USG has been done, and there had been 2 centimeter cervix is dilated. So patient is already dilated. Okay. So till what gestation emergency cerclage can be put? Anyone? Any guess?
At
Any
27
guess?
plus 6 weeks.
27 plus
Yes.
6.
Yes. So
Yes, 27 plus 6.
emergency cerclage can be put till 27 plus 6 days. So this is important because they have put now the number. So now the emergency cerclage. So insertion of emergency cerclage would be a sort of a salvage procedure for the premature dilatation when the fetal membranes are exposed in the vagina. Now how it can be find out clinically also, when we see the patient per speculum examination, or the patient will complains of some vaginal discharge, pressure, or on the cervix. So these are the few things. The emergency cerclage or the rescue cerclage can be put, and it can be put till 27 plus 6 days of gestation. Now, why we are doing emergency cerclage? Again, this question can be asked. So it delays birth by 34 days. So it is important to know that it delays birth by 34, sorry, what I said, I don't know. So it delays birth by 34 days. So this question can be asked in part 2. And also it decreases 2 times decrease in birth before 34 weeks. So these both of the things are very important, that we are this is the reason that emergency cerclage we are putting, because we can delay birth by 34 days, and they should be 2 times less in preterm before 34 weeks. So this is the like reason behind we are offering it. Now, in the emergency cerclage, if the dilatation is more than 4 centimeter, or like membrane prolapses there beyond cervical os, external os, then like ideally cervical cerclage should not be offered. Why? Because it will fail only. 4 centimeter, you can imagine, it is a very big, very advanced dilatation, and even bringing cervix lips together for the stitch would be very difficult, and so it would fail. So ideally it should not be offered if it is more than 4 centimeter, because it will fail only. Now, only on if the patient has a multiple pregnancy history or ultrasound related cerclage is not recommended. So they may give you a scenario where the patient have a history and the multiple pregnancy is there. So in that situation, you will not offer cervical cerclage. Apart from this, high BMI is associated with the preterm birth because of the high inflammatory response. So cerclage can be offered if the patient hasn't raised BMI. So raised BMI is sort of a not a reason where cerclage should not be offered. Apart from this, if any time history related or USG related cerclage, the whether it should be offered, the it is uncertain. If the patient only has a Mullerian anomaly, if the patient has previous cervical surgery, so in these kind of patient, only history or ultrasound related cerclage should be offered or not, that is uncertain. And apart from this, if there had been multiple dilatation and evacuation, so there is no difference. Because in this kind of conditions, there is no difference in preterm birth before 35 weeks of pregnancy. So only a patient has survived like Mullerian anomaly, so that would not be an indication for cervical cerclage. And only the patient has cone biopsy leads, that we will not offer cervical cerclage on the basis of this. So patient has to be on the follow up, then only they will do that. So only on the basis of this risk factor, cervical cerclage is not offered according to the guideline. Now again, what I said, vaginally it can be offered high vaginal and low vaginal, and this will be abdominal. Abdominal, again, there are two modes we already know, laparoscopy and laparotomy. So what is the difference in these? So transcervical cerclage, so this is McDonald procedure. So it is the purse string stitch suture placed at the cervico-isthmus junction, but only without any bladder mobilization. So just the patient is put in a lithotomy, anesthesia is given holding the two lips of cervix, and just at highest level cervico-isthmic junction, the suture is put. So this is very small procedure. So simple and small procedure that can be done in the labor room only when the patient is under anesthesia. So transvaginal McDonald, it is the easiest one. Now transvaginal, in this kind of cerclage, bladder is mobilized. After bladder is mobilized, then purse string suture is put at the level of cardinal ligaments. So it and this is Shirodkar. Though it is quite difficult and it can't be done without expertise, you can imagine doing this from the cervix would be quite difficult. Apart from this, transabdominal is done by laparotomy or laparoscopy, and suture is placed at the cervico-isthmic junction. So transabdominal cerclage, usually if it is done, because it will be done uh, like laparotomy and laparoscopy. So like it can be done like before pregnancy or in the early pregnancy. So why? Because the more bigger the baby is, putting cerclage becomes very difficult. So it can be done before patient get pregnant, or in the early pregnancy also it can be done. So apart from this, now this if the patient gives you history that she has got a cervical stitch was put, and even after that she had like preterm birth, or she had like late pregnancy loss, then that would be an indication for transabdominal cerclage. So failure of vaginal cerclage, another indication for transabdominal cerclage. It can be done before pregnancy, or it can be done in the early pregnancy. And if the preconception cerclage is done, then it would be technically easy because pregnancy is not, patient is not pregnant. So anesthetic risk will be less, and also there would be no fetal risk because the patient is not pregnant. Apart from this, it is easy also, and it is more effective, and they're not associated with any kind of subfertility. So the consideration for preconceptional or in the early pregnancy can be done. Now either it is done by laparoscopy or laparotomy. It depends on the efficacy. It will be same, like if you come to patient, that it will be same efficacious. But again, laparoscopy, if it is done laparoscopically, it can be done only by the people who do have expertise. So now another question. 34-year-old woman has come with a abdominal cerclage, and that is put in the previous pregnancy. Now she has miscarriages 17 weeks. So what will be the next step? So patient has an abdominal cerclage that is put in the previous pregnancy. Now she miscarried. What to be done?
Cut cerclage stitch posterior colbotomy.
Ma'am,
But
dilatation
it,
evacuation with stitch in situ up to 18 weeks.
yes, very good. So dilatation and evacuation with stitch in situ, because according to the guideline, now you can see. So if there had been delayed miscarriage and fetal death and within abdominal cerclage, so what are the options? So evacuation can be done by suction curettage or by dilatation, evacuation, and through the stitch. So stitch is there, and through the stitch they are doing. It can be done in 18 weeks of pregnancy. And if like it is not possible to do that, or if baby is of bigger gestation, then consideration of suture cut by posterior colpotomy can be done. So like another scenario, if they give that patient has a cervical abdominal cerclage, and like 20, 18 like 19 weeks or 20 weeks of pregnancy. So what to be done in that situation? You would put the answer, cut the stitch, and via posterior colpotomy. But if everything has been failed, cutting suture, because if it is put abdominally, the cutting it by posterior colpotomy will be difficult. So in that if it is difficult, then possibility of hysterotomy may be there. So first step, doing a dilatation evacuation through the stitch up to 18 weeks. Second option, cut the stitch via posterior colpotomy. Last option would be hysterotomy or cesarean section if the baby is big. So these would be a few things that you should know. Apart from this, there are certain contraindication for cerclage. If the patient is in active labor, if there is infection, like if you have got evidence the patient has choriomenitis, it's useless doing cerclage because patient is going to deliver only. If there is bleeding, if the membranes are already ruptured, if the fetal compromise, fetal death, or lethal fetal defect is there. These are the contraindications where cerclage will not be put. Because of that, when they are putting cerclage, they always check, do scan. Because for example, if the patient has an high NT, or if any congenital problem is there, why you will like to continue with the pregnancy? Because of that, they have to check it with whether any compromise defect or fetal death is there. In that situation, they will not be doing any cerclage. Now, when the cerclage is done, so a few small risks can happen. What can happen? Because like when they're putting sutures at cervicoisthmus junction, bladder is just coming down, so there could be bladder damage. They may tear, like they're putting the suture through the cervical tissue, so there could be cervical trauma. If the membrane are like bulging inside the cervix, there could be membrane rupture, there could be bleeding. So these are few things can happen. And uh, like uh, apart from this, if the patient, usually the cervical stitch is removed, but if the patient has a pain and the stitch is not removed, so there would be like laceration and trauma. Usually the tear that can, the bucket handle tear will happen to the cervix. Apart from this, high vaginal bladder mobilization is required. So it may require anesthesia, so an anesthetic risk would be there. So these are the few things that should be explained to the patient before she agrees to go for any kind of cerclage. Apart from this, if the patient is going for non-emergency cerclage, then usually like uh, prompt amnitis, increased induction of labor or cesarean section doesn't happen. So in the role player may ask you, if I go for click stage, do you think I have to go for cesarean section? Do you think I do have to induction labor to be started off? Answer would become no. Cervical stitch doesn't have, like cerclage will not affect all this. And apart from this, with if the insertion is done, we are doing it to delay the pregnancy, so pregnancy loss doesn't happen. If it is like planned procedure, in emergency procedure, all this complication may happen. But usually like preterm birth or second trimester loss will not be there, because membranes are not like bulging, so only cervical length is reduced. So usually in non-emergency circles this will not happen. Apart from this, yeah, this part will be same. If the patient delivers or in a labor and stitch is not removed, then trauma will happen, cervical laceration or trauma will happen. So the complication that can happen in non-emergency cerclage, definitely they are less. Now what are the when they are doing history related cerclage, so they will do investigations. So what are the investigation to be done? First trimester ultrasound scan or screening for aneuploidy, um, to make it sure that there is a single baby, because it is put in singleton pregnancy. Apart from this, there is no lethal or major anomaly is there. So usually we already know that the history related cerclage is put on usually in between 11 to 14 weeks of pregnancy. So like the complete anti-scan and screening to be done beforehand. For USG related cerclage is done when we are when we are doing the scan, usually like in between 16 to 24 weeks of pregnancy, and we find the cervical length is less. So by that time, anomaly scan is already done. So anomaly scan has to be done. That is a must investigation before USG related or before emergency cerclage. So these are the investigation that are required. This question may be asked in part 2, or you have to explain in to the patient in part 3 station. Apart from this, like if any if the patient is coming with any suspicion of infection, just like WBC count and C reactive protein can be done. But if there is no clinical sign, then cerclage can be offered without and doing any test. So in suspicion, CRP and WBC would be done, but it is not routine. Okay. Another question: the 32 weeks pregnant patient is due for emergency cerclage. Complaints of fever, and uh, CRP and FBC has already been sent, but there is a suspicion of amniotic infection. So what should be the next step?
Abandon Cerclage.
No, no, there is a suspicion of infection.
Amniocentesis before cerclage, ma'am.
Hmm. So amniocentesis before cerclage, and this is the answer here. So routine amniocentesis should not be done, and it is a routine amniocentesis is not recommended, but in selected cases where there is a suspicion of amniotic infection. Basically, maybe what I try to give message is this only. Maybe question was not that correctly formed. So if there is suspicion of intra amniotic infection, then amniocentesis may be performed to help a decision about the emergency cerclage. Because if the infection is there, usually the baby will deliver and stitch has to be cut. So it and if it is done during emergency cerclage before 28 weeks, so what they say, that preterm birth will not increase. So just then be very careful. So if any suspicion is there, on in the suspicion they will do amniocentesis. But the if the infection is confirmed, then they will not do it, then it will be abandoned. So this is the message I just wanted to give by the question. So in suspicion, amniocentesis, and in confirmed intraamniotic infection, abandon that cerclage, or that is would be the contraindication. So this part is important here. Now, routine genital infection test would not be done. Routine, it will not be done. But if any previous test is there and that shows there has been positive culture, then treatment will be done. Apart from this, after cerclage, usually people put the patient on tocolytic. So according to the guideline, a routine perioperative tocolysis should not be done, and routine antibiotic prophylaxis is not done. But if they want, they will do it, because we already know in UK they use uh, um, very less antibiotic, and the usually in the clean contaminated surgery only they give antibiotics. And in the cervical cerclage, no cavity is going to open, so usually antibiotic prophylaxis is not given, but it will be decided by the surgical team. Now use it is a very small procedure, like transvaginal. If it is done, so it can be done within, maybe with it's a very simple short procedure, so it can be done on a day basis. So it is only for the transvaginal. If it is abdominal, or if it is laparoscopy, we already know that in that situation it has to be done, patient has to be admitted. Now another few things what they say, that cerclage has to be there for at least 36 weeks. So non-absorbable, usually non-absorbable suture material is used. Okay, non-absorbable suture material. Apart from this, um, uh, uh, it should be placed as high as possible, whether they put one suture or whether they put two suture. Like at the cervicosmic junction, uh, whether one stitch is put or whether two is put, there is no difference. So putting one will be enough. Apart from this, some of the people, what they do at the external os, they occlude with the suture, but that doesn't help. So routinely it should not be done. These all are the recommendations for the switch operative part of the circular. So maybe asked in the some of the questions. SBS stems. Now post-op advice, bed rest is routinely not recommended. Apart from this, like abstinence from the cervical, from the sexual intercourse is also not recommended. Okay. Now few other things, like if the routine cervical if the cerclage has already been done, then like they don't want to do cervical screening, then routine cervical screening will not be done once the cerclage has been put. But sometime, according to the cases, if they wish, the decision has to be individualized, because if the still like the cervix is getting shorter, so in that situation, maybe they measure the cervix and decide when the intra-utero transfer has to be done, or when the steroid has to be done. So if they have to take some decision about the delivery, steroid, intrauterine transfer for a patient they're suspecting preterm, then even after getting cerclage, they would consider doing ultrasound. Otherwise, routinely after cerclage, cervical screening is not done. Even in the history related cerclage, they are not doing USG screening, because because um, like if the expectant management is done, and uh, like uh, uh, addition in the presence of history related cerclage, additional USG related, if they are doing cervical, usually they're not doing cervical USG screening, because if on the USG screening they found even after history related cerclage the cervix is short, then in that situation either they manage patient expectantly, or they put cerclage again. That will increase the chance of pregnancy loss and birth before 35 weeks of pregnancy. So even ultrasound indicated cerclage, after they have put history related cerclage, is not recommended, because the patient will go for the expectant management, because there is no increase if two times cerclage is done, there would be increase in pregnancy loss and birth before 35 weeks of pregnancy. I would speak about this again in a simple manner. If the patient has gone history related cerclage and they are not doing routine ultrasound, because if on the routine ultrasound they found the cervical length is still less, then they would manage the patient expectantly. They will not do USG related cerclage, because if that is done, then pregnancy loss and preterm birth would increase. So the main message is that once the cerclage is done, uh, in that after that, routine uh, USG screening for the cervical length, a guideline doesn't recommend. So in the USG related cerclage, they would just individualized, because they have to manage the patient, and in history related cerclage they are not doing it at all, because there would be increase in complication if the second stitch is put. So this is the message from this. So routine cervical scan is not done after cerclage has been already put in any patient. Now for the cervical insufficiency, routinely even the progesterone they are not giving after cerclage. So this would be important, that like once the cerclage is done, to increase its effectiveness, they're not giving any progesterone. Apart from this, as for the preterm, they use this arabin cervical pessary. So even this is even that is less effective. So either progesterone or arabin pessary, they are not offered after cervical cerclage. Now if the patient route of delivery, if the patient has transabdominal cerclage, in that situation, of course the mode of delivery is cesarean section. And when the cesarean section is done, then in that situation the suture for the cervical stitch will not be removed, it will be left behind. Because why? Because next time, that this is for the next time, If the patient get pregnant again, then like if the suture is already there, then that this suture will work for the next pregnancy also, because next time also the cesarean section will be done. So this is the one thing. Apart from this, during cesarean section, like if you removal of this suture is very difficult, because it because of the increased vascularity, and when we do dissection, it is very difficult to find out the stitch. Usually it get merges with the tissues. So abdominal cerclage removal is very difficult. Usually the mode of delivery would be by cesarean section, and the suture would be left. This is for the abdominal cerclage. Now, if the transvaginal cerclage has been put, then the recommendation for removal of stitch is in between 36 to 37 weeks of pregnancy. So this will be the usual time. So if it is vaginally it has been done, so it can be done in the labor ward only. So there would be no problem. This is very easy. Just hold the thread and cut the suture. But if the high vaginal has been done, like if the bladder mobilization, the stitch has been put, then it would not be that easy that to remove in the labor ward. In that situation, it has to be done under anesthesia. These are the few things that is important to understand. So you will get a question like when the stitch has to be removed. So it is 36 to 37 weeks of pregnancy, and transabdominal will be left as it is, and the delivery would be by cesarean section. Now another question: if a 33 years old woman presented with leaking, no other complaint, but she had got cerclage put at 24 weeks, what would be the next step? Now, the patient with the cerclage has come at 33 weeks with the leaking, and she's having no problem. So, what you'll do next?
Wait 48 hours for steroid and then cut stitch and deliver. 2 days
Yes,
for steroid to act.
yes. So, if the preterm pre-rupture membrane or rupture of membrane is there, in between 24 to 34 weeks of pregnancy, and there is no evidence of infection or preterm labor, then delayed removal of cerclage for 48 hours can be considered. Why? Because that will to give steroids and also to make arrangements for the in utero transfer. Another question similar kind. So this patient with 33 weeks with the leaking, with a chills, rigor, and discharge, she has got history of cerclage put at 24 weeks of pregnancy. So what would be the next step?
Cut stitch and deliver, doctor.
Cut stitch and deliver.
Yes, yes. Now the question is the message that I want to give here. The patient is having chorioamnitis. So if the infection is there, why you will keep the patient? uh, so in that situation, uh, like so from there the answer will come. If there is a risk of neonatal and maternal sepsis in prom, then delayed suture removal is unlikely to be advantageous. So what you will do? Cut the suture, deliver the baby. So this is the answer. Again same. So in prom, 30 to 34 weeks of pregnancy, patient is fine with no infection and preterm labor, delayed removal for 48 hours, so that antibiotic steroids and intrauterine transfer can be done. So apart from this, so delayed suture removal until labor ensures or birth indicated is associated with fetal risk of if it is associated with fetal and maternal risk, then it is not recommended. So we should not delay. So same thing, if we think that the patient will develop chorioamnitis or infection or baby will have any problem, then in that situation delay should not be done. And if the evidence of sepsis is there, then you have to deliver immediately. So from here, this part also question comes. They will similar kind of question. The patient has a prom, and she has got no infection. Then in that situation you delay it by 48 hours. If they give you scenario that any risk of infection to mother and baby, then you have to deliver cut the suture and deliver the baby immediately. If the prom is there, then also. Okay, that's all about it. This much is the details of the this in this guideline. So almost similar thing, that the changes that are there is what I already told you, that they have divided for the surveillance, they have divided the women in high risk and intermediate risk, and their cervical, their cervical mm, scan, the frequency is changed. Only this part had been a little change in the guideline. Apart from this, rescue cerclage, in previous guideline they say that it will delay the birth by like uh, 33 days, but in this new guideline they have put it 34 days. So these are the few changes. That's all about this guideline. So with this you'll be able to answer your part 2 questions and part 3 station also. So any one of you have got any question can ask me.
Ma'am, I
Any?
want to, hello.
Yes, yes.
Ma'am, regarding the role of cervical encerclage in women with high body mass index. So in women, is there a cutoff criteria for the BMI where they have to have a
No,
prophylactic cerclage?
no, no. They have not given anything about it. This is also newly added in this guideline. Previously, it was not there. What they say, like if the BMI is also associated with preterm, so it is not only on the basis of BMI they will put cerclage. They will look at like criteria for the history related, USG related, and also with the emergency. On those criteria only the cerclage will be done. So what they say that BMI will add to it. So if high BMI is there, they will do it, but
Okay,
only on the basis of BMI it will not be done. Criteria will be for the cerclage according to the guideline. Still it will be either history related or scan related, or it will be emergency.
right,
These guidelines divide them into three parts.
right,
So
ma'am.
these,
And
yes, has to be followed. Yes.
ma'am, and also regarding amniocentesis, when we are doing
Hmm.
amniocentesis prior to an emergency in cerclage where there's suspicion of any infection, then
Hmm.
this amniocentesis, do we wait for the result and then apply the encerclage, or do we just put the encerclage because it's an emergency situation?
Yeah, in that situation, that clear uniform answer would not be there. So again individualized approach has to be done, because like if they have got, if they think that there could be possibility of like sepsis is there, then they will not put it. So like if they are suspecting, then only they will do amniocentesis. And I think it is an emergency, they will put cerclage, because waiting for the result will again take at least 2 days, and
Right,
in
ma'am.
the emergency the delivery will happen by that time.
Okay, then it can help in the management subsequently with the antibiotics. Okay, fine. Thank you so much, ma'am.
Anyone, any other question? Anyone, any other question? Okay, thank you for joining. All the best, and bye.